Yep. All right. Terrific. So these are my disclosures. And so today we'll focus on recognizing presentations and the impact of interstitial lung diseases in children. The real focus of the talk will be how to diagnose them as well as recognizing them. And then I'll try to share what I see as opportunities for discovery and how we can accelerate progress in this field. So just to orient everyone, the interstitial space is really the space in the lung between the alveolar capillary membrane, as is depicted here. So it should be a virtual or very small space. But in interstitial lung disease, we use this term whenever there's any disruption of this space between alveoli. So it could be, as shown here, with an inflammatory cell infiltrate, and then pulmonary fibrosis is really just an advanced form of more diffuse lung disease. So broadly speaking, anything that perturbs the space of the interstitium, those of us who are ILD enthusiasts would umbrella under interstitial lung disease. But we're a little bit broader than that because it also will use the term to include diseases that impact the terminal respiratory units or the acinus. So respiratory bronchioles, anything that starts to look like interstitial lung disease and approach that area will often be classified as a type of interstitial lung disease, though the primary pathogenesis may not be in the interstitium of the lung, truly speaking. So probably it's better to think about this as diffuse lung disease and to think about imaging as an entry point. Because these are very heterogeneous disorders. They're not one thing, as we'll talk about today, but their clinical presentations overlap. But ILD is a little bit better nomenclature in the literature historically, but again, think about diffuse lung disease. And we'll talk today about the genetic and molecular mechanisms for which there's been a lot of progress. Historically, ILD was thought of as a dreadful diagnosis to make with very high morbidity, but as we'll discuss some today, the outcomes really vary based on the subtype. So I want to share with you a little bit of my early introduction to interstitial lung disease, especially with this being a fellows track presentation, and have permission to share this case from this family. So this actually, this patient I met the first day of my fellowship in Cincinnati. He had been a term infant who had had unexplained respiratory failure and had remained oxygen dependent, been called idiopathic interstitial lung disease, been called IPF, and had undergone a lung transplant actually at St. Louis when he was 5 years old. And so I met him about the time he looked pretty similar to what you see in this picture and really had some good quality of life playing baseball. Unfortunately, during the course of that first year, he developed chronic rejection or bronchiolitis obliterans syndrome and died at the end of my first year of fellowship. We didn't know why he had ILD at the time. We tried to review the case. We looked at others for comparison, and it wasn't until a couple years later when Larry Nogi and colleagues at Hopkins discovered ABCA3 mutations as a cause of neonatal respiratory failure that we went back to his case and were able to make the diagnosis retrospectively in this patient. So his father actually became the founding president of the Child Foundation and has been of service to the ATS and president of the Public Advisory Roundtable of the ATS. And this group has provided a lot of synergy with other rare lung disease advocacy groups and a lot of inspiration to many of us. I also took care of a patient during fellowship who was a teenager who was eventually found to have polymyositis. So this is a very different type of interstitial lung disease, and what I hope you see here are these subpleural predominant opacities and then a lung biopsy that showed very dense fibrosis. And I'll just make the comment here, it's important to think about the fact that there actually is a fair amount of normal lung on the CT, but when you look at the biopsy pictures I'm showing you, it looks like there's almost no normal lung. So as we'll talk more later, just a reminder that what you see is based on what you sample. So these two very disparate types of interstitial lung disease, at the time, it was just starting to be recognized that we probably needed to work harder to separate interstitial lung disease in children from the forms seen in adults. The predominant form in adults is idiopathic pulmonary fibrosis that has had a 5-year mortality of about 50%. The patient, the teenager that I saw you, connective tissue disease, we could kind of think, well, there's some overlap in what might happen in kids and adults. But there were other forms that were emerging in children that clearly seemed quite different. And so Leland Fan really established this field of childhood ILD, and I wanted to recognize that in giving you this lecture. He wrote all the early chapters, and some of the papers that were shown here looked at evaluation and therapy and how to diagnose by biopsy, proposed different diagnostic algorithms. And then importantly, he really pushed us to think about the nomenclature, because he went back through the literature of all the pediatric cases that had been called usual interstitial pneumonia or idiopathic pulmonary fibrosis, this adult type of ILD. And he reviewed all those cases from the literature and realized that unlike the 50% mortality that normally occurred in adults, there had been very low mortality in kids. And actually, the cases lacked the histopathologic features of UIP. So we're using the term idiopathic pulmonary fibrosis because they're idiopathic to us, but they really were different. Around this time as well, there were some key discoveries in pediatrics that I've highlighted here of forms of ILD in children, including discovery of how surfactant protein B and C and ABCA3 were associated with ILD, and then of this disease called NEHI, or Neuroendocrine cell hyperplasia of infancy. So those things sort of came together to lead to forming what was called the Children's Interstitial Lung Disease, or Child Research Network. In 2004, it had support from a Rare Diseases Consortium grant based in Cincinnati at the time. And I was just finishing my fellowship and had the privilege of being involved in this and getting to work with the individuals I've just shown you. And the plan was made to really develop consensus terminology and diagnostic criteria. So we reviewed lung biopsies performed for diffuse lung disease from 11 to 12 centers with about a 4 to 5 year catchment period. It took us a long time to review all of these cases, but through that, we developed some common language and an understanding of the spectrum of ILD, or diffuse lung disease, in children. That led to subsequent work to then develop an ATS clinical guideline, and this research network has monthly conference calls, case presentations, and has been holding various educational research conferences near annually for the last 15 years. So this classification system at the time was called diffuse lung disease in young children. It was based on histopathology. Obviously, the field has changed, but Gail Deutsch is the pathologist now at Seattle Children's who led this work. And essentially, the classification system took into account both clinical and pathologic features, and then took these cases and tried to see how they fit. And so I'm happy to say that, 13 years later, we've learned a lot, and this classification system was a good framework at the time, and it has features that are still very useful, but there are other things that have changed. And so I'm not going to focus a lot on the classification today, and instead I'm going to take you through different types of ILD based on the new molecular information. But just as pediatric lung disease evolved, adult ILD has too. And so I want you to know that a lot of what was called idiopathic pulmonary fibrosis is no longer idiopathic. It was recognized many years ago that there was a positive family history for about 20% of cases, and that these family cases looked identical in clinical course, imaging, histopathology to the sporadic cases. It turns out that mutations in the surfactant pathways are very rare causes of disease in adults, and that telomere or telomerase-associated pathways predominate, with more genetics yet to be understood. So in addition to these rare variants, there are also roles for common variants as risk alleles as well. But again, just as the childhood forms have undergone more molecular understanding, the adult form as well. So as I give context to the different types of diseases I'll talk about today, I've told you you could use the term ILD, you could use the term diffuse lung disease. Some of us also use the term rare lung diseases. Cystic fibrosis is a rare lung disease, primary ciliary dyskinesia. Some of the ones we'll be talking today are probably more rare, but there are a lot of them. I promise you we won't go through all of them today, but we are going to do a little bit of a whirlwind tour through some. So what's the prevalence? The short answer is that we don't know. There's published data ranging from about 1 to 4 cases per million is what is in the literature. But the data just for those where we've found a genetic cause suggests that these figures would be vast underestimates. So surfactant protein B mutations are one of the rarest causes, but population data puts that at 1 per million. So if we have 100 or more different causes and one of the rarer ones is at 1 per million, you can see that our numbers are off. But the epidemiologic assessments are challenged by different studies using different case definitions, different ascertainment methods. So there's some studies that report prevalence based on requiring lung biopsy for inclusion, but we know that most patients don't undergo lung biopsy. There are other papers in the literature that excluded children with immunodeficiency, although we know that there are types of ILD associated with immunodeficiency or immune dysregulation. So just, as you're asked how common is this, and you look at different literature, just understand some of these limitations, and maybe at some point we'll have better epidemiologic ways to do this as opposed to just case ascertainment. But right now, most of what we do is case ascertainment. From those case ascertainment studies, though, we know that while they're rare, these cases exist everywhere. At every children's hospital around the country, as ILD centers have been set up and people have worked to look for cases, they find more and more. And some of that is because these kids present in a variety of different clinical settings. So you have to look for them and think about it, but they may be in the neonatal ICU or in the cardiac ICUs. Rheumatology or connective tissue diseases are associated with a lot of ILD. Patients receiving chemotherapy or stem cell transplant develop ILD complications. And certainly throughout these other areas. So to me, this is part of the fun of what I think many of us like about pulmonary is that we spend time in different areas, get to think about different systemic diseases, and really function at the intersections as consultants. But as we look for these cases, part of the challenge is that the clinical signs and symptoms for ILD really overlap with other more common disorders. So this is data from that network paper that I told you about where we pulled lung biopsy cases and looked at clinical features. And really the majority had hypoxemia, tachypnea, retractions, about half had reflux, some had pulmonary hypertension, failure to thrive was pretty common. Sometimes they had crackles, sometimes they had wheeze, sometimes they coughed, sometimes it was a quiet chest. So there's not a specific algorithm that you can use. These things overlap with many other things, but many of us think it's helpful to think about ILD syndrome as a starting point when you start thinking, do I need to evaluate this kid for possible ILD? So when you start thinking about that, the first thing to do is to pause and to exclude more common causes for these symptoms. So this is from the ATS clinical practice guideline from 2013, recommending to consider, doesn't mean you have to do all these things, but consider evaluating and treating for infection, structural heart disease, anatomic or large airway abnormalities, as well as aspiration, cystic fibrosis. Do not want to diagnose that with a lung biopsy. Double check an immunodeficiency, but remembering that sometimes you may identify a comorbid diagnosis, not the underlying cause. But these are still good things to pause and to think through carefully before you start thinking about some of the more rare disorders we'll talk about today. So once you've done those things, then it's really the clinical context that helps you think about the differential diagnosis and your approach. So you'll think about age of onset of symptoms. One of the most useful things about that 2007 classification was really thinking about disorders that are more prevalent in infancy compared to things that happen in older kids. The family history can be helpful. And then as you're trying to decide less invasive to more invasive testing, think about, does this child need oxygen? What's their nutritional status? Do they have pulmonary hypertension, which is a poor prognostic factor in ILD as well as another lung disease? And then what's the clinical course? Is it progressing? Is it persistent? And if so, if it's just persistent, how bad a place is it persisting in? Or is the child improving? Because this really influences your need to know, your need to establish a more definitive diagnosis and how it would inform treatment. So as you do that, the general considerations for diagnosing ILD are going to be chest CT, genetic testing, and or lung biopsy. And the technique and details of these things are pretty critical, and I'll try to share just a few examples. So chest CT increasingly can suggest a specific diagnosis in certain cases, and therefore help with treatment decisions and avoid the need for lung biopsy. But depending on the circumstances at your center, get to know your chest radiologist. The technique is really critical, especially in young children. And the field has changed, which is a good thing. But for a long time, we advocated for performing chest CT in infants and toddlers utilizing sedation or anesthesia in order to avoid respiratory motion artifact and get raised volumes to get inspiratory and then expiratory images. And of course, with sedation or anesthesia, you immediately get atelectasis. So you have to do recruitment maneuvers and check your scalp film and those types of things. And I used to spend a lot of time coaching people around the country through how to do this. But the practice is shifting now, fortunately, with faster scanners at many centers and ability also to minimize radiation dose. So there are many kids now that for the majority, will not need sedation or anesthesia for ILD type chest CTs. One important point to think about is the need for expiratory imaging. Really is more for air trapping and small airway disorders. And for many types of ILD, I think it's not always needed, and that's a way to also reduce the radiation dose. And then also, if you have a young child, you're obviously not going to get an inspiratory and expiratory series. So before you intubate or use anesthesia to do inspiratory, expiratory imaging on a child, you want to really think about whether you truly need the expiratory imaging. So when do you need to do a lung biopsy? Well, the short answer is if the other studies fail to provide a diagnosis and the clinical urgency dictates, then surgical lung biopsy, typically via VATS, video-assisted thoracoscopic surgery, should be considered. But the biopsy site's going to be critical. So let's look at this case. This is a 16-year-old who had exercise intolerance. PFTs had a moderate restrictive defect and reduced diffusing capacity. And the chest CT here shows diffuse ground glass opacities. I saw her in consultation, sadly, when everyone was puzzled because there was this near normal lung biopsy that you're seeing here. And so the lesson of this is, how do you get from this CT scan to this lung biopsy? Well, the biopsy was taken from the tip of the lingula, which was one of the more spared areas, but is easily accessible. Didn't biopsy multiple sites, went there. And so that fit. We knew it was from the tip of the lingula by the op report, and then by the fact that she later had a follow-up CT scan and we were able to see the suture line. So you don't do the biopsy yourself as the pulmonologist, but you convince the family that this is the next step in their evaluation, and then you sit with them in the office to discuss the results. And this is a position we never want to be in. So yes, it takes a lot of time and effort to have communication between the radiologist and the surgeon and to plan where you're going to go. But I hope you'll remember this case and take those steps. The other place where things can go wrong for a lung biopsy is with the tissue handling. And one of the things that our ILD network pathology group first did was to put out a guideline about approach to handling lung biopsies, because from those studies, the experience was that 10 to 15% of lung biopsies were non-diagnostic because of inadequate tissue sampling or tissue processing. So in general, it's preferable to have biopsies from more than one site, usually two, always on the same side of the chest, the same lung. And to think about how those samples are obtained. There are some things that the pathologist needs to do with the tissue when it's fresh, or they can't go back and do other types of studies, in particular, thinking about glutaraldehyde fixation to be able to do electron microscopy, and snap freezing some tissue is really important, especially now for molecular studies. So if the whole biopsy just goes in formalin in the OR, you're not able to do these things. So more work to do with the pathologist. But over time, fortunately, I think, although I've learned a lot from lung biopsies and we'll show a lot of cases today, there's really a growing role for genetic testing and evaluation of interstitial lung disease. And these are lists of some of the genes that are implicated and that we see more cases of. And as I take you on a tour through some of what these things look like, I just want to pause and mention that genetic counseling should be strongly considered whenever you're sending these panels. The family should know the panel's being sent and have the opportunity for genetic counseling. Think about the timing of the testing. If you want to avoid a lung biopsy, you want to think about doing the testing a little bit early. It doesn't make sense to do the genetic testing and then do the lung biopsy the next day. If you want to, often want to try to avoid that lung biopsy if you're sending the genetic testing. And then to remember the limitations of the testing. There are different panels that are done now. Certain panels contain certain genes, but not others. Many are, going to an exome, but you will get variants of unknown significance, and this is very difficult and also can cause a lot of anxiety for families. It's not uncommon to have a well-meaning nurse, resident care team member say, oh yeah, something came back. They found something on the report, and it's a variant of unknown significance, which is unlikely to be pathogenic, but it creates a lot of anxiety for everyone. So I'll talk first about disorders of surfactant production and catabolism. They can present with neonatal respiratory failure or with ILD in older children. Cough, reflux, and failure to thrive are quite common with this. The clinical context as well as the family history can be very helpful, as we'll talk about, as well as the radiographic patterns. And most of these cases now should be diagnosed by genetic testing, not by lung biopsy. Although there are some cases where a lung biopsy is done, it suggests a surfactant disorder, but the genetic sequencing doesn't identify a cause, suggesting that there are additional genes to be discovered. So, surfactant production and catabolism. The type 2 alveolar epithelial cell, shown in blue on the left, makes the surfactant. The macrophage, shown on the right, is involved in clearance as the way to, as a simplified version to think about this. And so anywhere in the process of producing surfactant protein, processing it and secreting it, you get genetic defects of surfactant production. And then you get abnormalities or surfactant clearance and things that affect macrophage function. The histopathology overlaps. And so the pathologists have used these terms over the years and still do. PAP, diffuse alveolar damage, chronic pneumonitis of infancy was in the literature a lot about 20 years ago. Desquamative interstitial pneumonitis, which in adults is associated with smoking disease, but in kids we learned is associated with surfactant disorders. NSIP. These kinds of pathology terms are what taught us to then go look for mutations in these surfactant genes, but there can be different types of histologic patterns seen with the same gene abnormality. So what you're seeing here in the pictures are accumulations of macrophages in the alveoli here, and then expansion of the interstitium. This is maybe an easier area to see it over here. This should be nice and thin, but instead is thickened, and then accumulations of macrophages here. Over here, this is more PAP-like material, more proteinaceous or alveolar filling. Okay, so surfactant protein B, you get disease associated with recessive mutations, presents with neonatal RDS, and most cases are fatal without lung transplant, though there have been a few cases with partial loss of function mutations and slightly better outcomes. But this is usually a problem immediately in the neonatal ICU, with a chest x-ray that otherwise looks like RDS in a preterm infant. ABCA3, or ATP binding cassette member A3, is a transmembrane protein on the limiting membrane of lamellar bodies, where surfactant is packaged in secreted. And so this protein, ABCA3, which is a cousin of CFTR, by the way, facilitates transport of lipids that are essential for surfactant production. So it's not a surfactant protein itself, but it helps move the lipids that are needed to make surfactant. It also causes disease predominantly in a recessive manner. but it causes an age-varying spectrum of the radiologic and histologic findings. So here you have a chest X-ray with this kind of diffuse RDS pattern, a chest CT which shows what's called a crazy paving pattern, where you have diffuse ground glass opacity but with reticulation. And then the lung biopsy showing, again, alveolar filling, inflammation, interstitial expansion. And so this was a neonatal case that we saw many years ago. But this was another case in a 15-year-old who started smoking as a teenager and had some exercise intolerance and didn't get benefit from an albuterol inhaler. And another physician noticed his digital clubbing and referred him quite astutely. And this is what his chest CT looked like. And lung biopsy, this was before we were able to do clinical testing, as that was just emerging and didn't recognize the patterns. For modern day, for either of these kids, I would hope that they would get genetic testing, and I would not have lung biopsy pictures of their cases to show you. So in ABCA3-associated disease, there's really been some nice work looking at genotype-phenotype correlations. This work was done by Jem Wambach at WashU and Alicia Casey at Boston Children's in collaboration with data sets that Aaron Hamvis and Larry Nogi had assembled over many years. And essentially it makes sense, right? So all of us in CF understand how important it is to know the genotype. But we're just starting to do that work in ABCA3 and in these other diseases. But so in this data set, if for patients who had null mutations, there was 100% mortality or progression to transplant by 1 year of age. If there was a null mutation and another mutation, or other mutations other than null mutations, there was better survival. Makes sense, but again, another reason to look carefully at the information before we give reports to families about what the genetic testing shows and what the implications might be. Another thing that's fascinating about ABCA3 is that a single heterozygous variant matters. So the full-blown ILD is homozygous, recessive, but being a carrier for ABCA3 matters. And Jen Wambach and the group at WashU has shown very nicely how single ABCA3 variants are associated with an increased risk of RDS in preterm infants. So this is an example of how a rare disease has taught us other things about a more common one. This is a case I'll share that I think is helpful in how to try to think about picking out kids with ILD from among the more common things. So this is a 6-month-old who presented with RSV bronchiolitis, but just couldn't wean off oxygen. Had been a healthy term infant, but in really kind of digging into the history, there had been some low-level concerns prior to the acute illness, kind of always chest congestion, a little bit grunting that the family thought was just sort of fussiness, but didn't feed well. And while the weight on the growth curve was still okay at 6 months of age, there had been a decline in the trajectory. But, you know, amidst bronchiolitis season, otherwise looked like another kid with bronchiolitis, and did have bronchiolitis with RSV. But because of the history of the slow wean off of oxygen, eventually had this chest CT scan, which showed diffuse ground glass opacities and some reticulation. And that led to genetic testing, which revealed the most common mutation in the surfactant protein C gene, or SFTPC, which is a variant called I73T, which accounts for about 30% of cases. So with surfactant protein C, unlike surfactant protein B and ABCA3, 50% of the cases are autosomal dominant, or with variable penetrance, though. And then others are sporadic disease caused by a de novo single mutation. So what happened in this case? So surfactant protein C disease is not simply surfactant protein C deficiency. There's a toxic gain of function mechanism. So you're basically making abnormal surfactant that is deleterious to the type 2 alveolar epithelial cells. And so the mutation causes abnormal folding, impairment of the surfactant composition and function, and it results in what's called endoplasmic reticulum, or ER stress, unfolded protein response, impaired autophagy, basically things that make your type 2 alveolar epithelial cells very unhappy, releasing inflammatory cytokines and other signals. And there's really strong evidence for an interaction between viruses and this mutant form of surfactant protein C in epithelial cells. So this is an example of how virus may bring these patients to clinical attention. Surfactant protein C disease is pretty fascinating in that it has quite variable severity with a wide range of presentations from infants, children, adults, and also asymptomatic individuals in the same family. I showed this series of CT scans from another group. It's the same child at 3 months, 6 months, and 15 months of age, just to underscore a pattern that I've seen in my own patients where the CT scan patterns change over time. So you have to be careful not to simply call things progression or improvement, because I think there can be an evolution with this where they develop more ground glass opacity and alveolar filling, and then as they get older, we'll get the cystic change and remodeling of the lung more towards adult ILD. So this is even without treatment, the patterns change in age-dependent ways. So next, I'm going to continue this tour to go through some other types of causes of ILD and talk about NKX 2.1 or thyroid transcription factor 1. Disease occurs due to loss of function variants or deletions of one allele. So again, heterozygous, like surfactant protein C heterozygous. This is a transcription factor that regulates the expression of many other genes, including surfactant genes. It can cause what's called brain thyroid lung syndrome. So there can be congenital hypothyroidism or chorea, so your patients with movement disorders in the movement disorders clinic, maybe some of your lung disease patients. Sometimes they have lung disease as the sole manifestation though. And the CT findings in histopathology vary quite a bit with some examples shown here. You can have abnormal lung development. You can have more of a surfactant accumulation phenotype. So I won't go through lung development timelines in detail, but I wanted to just take the opportunity to show we're going to talk about some types of lung diseases that hit at different time points in lung development. And so the first is just to talk about alveolar growth abnormalities. This confuses everyone when I put it into a talk on ILD, and it certainly confused me when I first started looking at lung biopsies that I thought were going to be ILD, and instead the cases had abnormal alveolarization, abnormal lung development. And it's because, again, this concept of diffuse lung disease and of ILD syndrome, that these weren't just preterm kids, although some of them were, but they were felt to have things out of proportion, or they had CT scans that confused people at the time. So it's not unusual to have a lung biopsy done for ILD that shows abnormal lung development. Some of the imaging findings include irregular opacities, lobular hyperinflation, and cysts. And sometimes the CT scans look pretty terrible, but sometimes the kids really improve as they grow. So this is essentially the idea of increased alveolar size and decreased complexity. We don't have good ways to quantitate this. From a lung biopsy, it really depends a lot on the tissue inflation and how it's fixed. But these images here are all shown at the same magnification. So yes, there's a preterm infant with chronic neonatal lung disease, and you can see how many alveoli there are or aren't, or how big they are compared to the normal term lung, but also just show you the examples of oligohydramnios or a patient with pulmonary stenosis, pulmonic stenosis, that was ultimately transplanted. So this type of pathology is technically interstitial lung disease. The interstitium is perturbed, it's thickened, but it might not be what you start off thinking about. But we need to learn more to understand the CT patterns and the risk factors. Trisomy 21 will do a lot of bad things and will certainly cause confusion on CT scans as well. But subpleural cysts are quite common. And so you'll see that aligning the fissures as well as subpleurally, and just wanted to point that out from an imaging standpoint. I think lung biopsies really aren't needed in most kids with trisomy 21, but sometimes they're taken at the time of a cardiac repair, especially for a kid who seems to have trouble out of proportion to their cardiac physiology. So most of the examples I've seen over my career were biopsies that the cardiologist wanted more than I did. All right, we'll take a breath and keep going. Filament A is one that we've not known about in the lung disease world for but really a handful of years. It's associated with periventricular nodular heterotopia, so you'll see that by ultrasound or by MRI, and there can be quite severe pulmonary complications with hyperinflation and hyperlucency, dependent atelectasis, respiratory failure. I've seen pulmonary hemorrhage. The group at Texas reported successful lung transplants in several, and this is generally X-linked. But when the actin cytoskeleton doesn't work, things don't go well in the lung, and that's what some of these cases reflect. TBX4 is a transcription factor that's important for the mesoderm differentiation and proliferation. So it's in the lung mesenchyme, so interstitium, but also the cardiac atrium and limbs. The lung disease that we're starting to learn about can include acinar dysplasia, so abnormal lung development, as well as pulmonary hypertension. And it's part of a pathway that results in an interesting phenotypic spectrum. Alveolar capillary dysplasia with misalignment of the pulmonary veins is a mouthful, but one you should know about because it's one of the sort of worst forms of causes of neonatal respiratory failure with refractory pulmonary hypertension. The majority of cases are associated with heterozygous disruption in FOXF1. Some of the patients have hypoplastic left heart, intestinal malrotation, or renal abnormalities. So if you're consulted for an infant with neonatal respiratory failure, you're thinking about surfactant disorders, you're going to also put this on your list. You're going to want to look for these extrapulmonary clues. Because FOXF1 plays a role in development of vasculature, you may see extrapulmonary manifestations, and the name for it came because of the pulmonary veins being malpositioned, as shown here within bronchovascular bundles. But there's a lot of work going on about whether that's really what causes all of the problems or why we see that and why it can only be patchy. But alveolar capillary dysplasia with misalignment of the pulmonary veins, generally a problem in the first days of life, infants to ECMO, unless they're born at a transplant center. Very, very challenging, although there are some milder incomplete penetrant phenotypes, and some patients present later or do well a little bit longer. This entity called pulmonary interstitial glycogenosis has a terrible acronym, and I try to say the mouthful instead of calling it P.I.G or PIG to parents. But it's only found in young infants, generally less than 6 months of age. They usually present with tachypnea, hypoxemia, diffuse infiltrates. Some can have severe pulmonary hypertension, even requiring ECMO. So it can be really indistinguishable from more lethal developmental disorders like the alveolar capillary dysplasia. So these patients can be very sick. Sometimes they can be milder. But what you're seeing are in these pictures on the histology is expansion of the interstitium with these abnormal cells that for a long time no one was quite sure what they were, but we just never saw it in older kids. And what we've learned over time is that this really occurs in different clinical contexts, but all contexts of neonatal injury or insult in the context of lung development. So it's often patchy in association with abnormal lung development, the deficient alveoli shown here. Seen it in infants that have had meconium aspiration and just not gotten better and gotten a biopsy and seen this. Sometimes when a CPAM has been taken out, we find this within there. And then Gail Deutsch has done some really nice work in recent years suggesting that these are what cells called lipofibroblasts, which are really telling us a lot about the lung developmental phenotype with this. There's some, I just want to give a word of caution. There's some literature about anecdotal response to glucocorticoids. It's a good way to get chased out of your NICU very quickly and to start talking about big doses of steroids to babies in the NICU, but sometimes it makes sense. The prognosis for these kids, I think, is really driven by their comorbidities, what their lung development is like, and the other issues going on. So you'll hear about pulmonary interstitial glycogenosis. Don't be in too much of a rush to give steroids. Don't give them for too long if you do give them, and think about what else is going on with the child. All right. NEHI. So neuroendocrine cell hyperplasia of infancy presents in the first year of life with chronic tachypnea, retractions, and hypoxemia. But importantly, there's usually no significant symptoms at birth. So this should not be on your differential in the NICU of a kid with neonatal respiratory failure. Crackles are usually present, usually not wheezing. There's no sustained response to bronchodilators or steroids. And this is a study done by Rebecca Neville, and she was a fellow at Vanderbilt with me, looking at when respiratory symptoms started in relation to the growth curve, in relation to oxygen. And these kids really fall off the growth curve and then improve with oxygen. Unlike other forms of ILD that I've shown you, gradual improvement occurs. These kids may need supplemental oxygen for years, but there's no progression to lung transplant or deaths reported, though we've done some longer term follow-up studies and see some persistence of respiratory impairment into adolescence. So these kids breathe really fast, but they're happy despite that. The hypoxemia can fluctuate. You may need to study them during sleep or with feeding. They're often markedly hyperinflated, that you can see best here by the lateral chest radiograph. And like other kids with ILD, they may come to attention when they have a superimposed viral illness, but the parents will tell you they always breathe like this. And now that, with phones, they'll often have video. And so if you get stuck in a consult, try to not put words in the parent's mouth, but just, ask them what they looked like before they got sick, or, see if they have video from prior to that illness. This disease got its name based on the presence of increased neuroendocrine cells amidst what's otherwise near normal histology. There's not inflammation in them. Bombacin is the immunostain that best highlights these neuroendocrine cells. We all have them. You're supposed to have them. But in NEHI, there are too many. But we don't usually do biopsies anymore for NEHI because it's become apparent that there's a distinct chest CT pattern. This is the classic pattern that's shown here with ground glass opacity medially in the upper lobes, and then most prominent in the right middle lobe and lingula. Importantly, there should not be any significant parenchymal abnormalities present. You should not have bronchiectasis. Not all NEHI CTs look like this, but with this pattern, it's highly specific for NEHI, and in the appropriate clinical context, you don't need to do a biopsy. So this is an exciting area of progress for a disease that didn't have a name when I was a fellow. I know that there was already a Fellows Track Symposium talk about connective tissue diseases and lung disease, so I've not included much here, but I do want to show some of the patterns that make you think about connective tissue disease. So if you didn't already know the patient had a rheumatologic disorder, if you see the subpleural findings with reticulation and ground glass, those are, especially in older children, histopathology will show multi-compartment disease. So you can have airway involvement, vascular involvement, pleuritis. Again, we don't do lung biopsies for most patients if they have a known connective tissue disorder, unless their lung disease is out of proportion or not responding to their immunomodulatory therapy. But large list of patients with rheumatologic disease who have ILD, but that we follow. I know there also was a talk about immunodeficiency, and so I want to just take a moment and remind you that think about immune dysregulation, and there's a lot of lung disease other than infection that occurs in these patients with a lot of new genetic and molecular understanding. Immune dysregulation or immunodeficiency accounts for a large portion of why kids have lung biopsies throughout children's hospitals. Sometimes the immune dysfunction is not apparent. There's a long list of genetic mechanisms that provide a lot of potential for targeted immunomodulatory therapy. So too many purple cells, spleen in the lung, it gets different terminology based on where it is geographically. So this follicular bronchiolitis is with the germinal centers surrounding or squashing an airway here. It'll be called lymphocytic interstitial pneumonia, where it's just sort of smattered throughout the lung. You can get all the way to a frank lymphoproliferative spectrum disease as well. Just a few others to mention. One is a syndrome called COPA, or codomer-associated protein. This is autosomal, causes disease in an autosomal dominant manner, but again with variable penetrance. Some of these patients will have pulmonary hemorrhage, quite prominent pulmonary hemorrhage. They can have other interstitial lung disease, may also have inflammatory arthritis and autoantibodies. This protein is involved in trafficking retrograde from the Golgi to ER, and so you get ER stress in the lung and a Th17 type phenotype. The CT scans that I'm showing you here are what are reported with this disorder. I don't know that I could tell you that it's, from looking at these, that this is COPA as opposed to something else, but certainly with cystic disease and other interstitial lung disease, if you had pulmonary hemorrhage, this very much should be on the list. There are too many other things for me to go through all of them, but I will mention that bronchiolitis obliterans is something that those of us in ILD include within our umbrella, although it's a small airway disease. And I want to show this CT just as a reminder that just because you have ground glass opacities or mosaicism, if there's bronchiectasis, you have to really worry about bronchiolitis obliterans. This can be post-infectious, associated with stem cell transplant, lung transplant, as you'll hear about. And then just remember that there are many different causes of injury to the lung that will cause interstitial lung disease, and there's some kids that we all take care of that we're still trying to understand why they have lung disease. So we're nearing the end of the time, and you'll note that I haven't talked a whole lot about therapy. This field's made a lot more progress with diagnosis than with therapy, but it's coming. Empiric therapies often include glucocorticoids and other immunomodulatory agents, but there are no controlled trials. Monitoring and supportive growth and nutrition are really critical, especially for young children. Developmental screening and therapies, immunizations, treating comorbidities at present, screening for pulmonary hypertension, and family support are sort of the pulmonary 101 of things that will apply to all of these patients. Now, I'm always asked about steroids and how to approach this. And again, no good data. The treatment decisions are really on a case-by-case basis. And again, we just encourage you to benchmark how severe is the disease, what's the rate of progression, because you're looking at doing an N of 1 trial. So you really want to understand, is this getting worse? What's the prognosis without treatment? What are the comorbidities? And how are you going to measure the treatment response? What's going to be the timeline that you do it so you don't wind up with a lot of side effects without being sure whether it's helping? And if you do use chronic glucocorticoids, just remember the importance of monitoring for side effects. Along with glucocorticoids, with starting them, you should be immediately thinking about your steroid-sparing approaches, whether other immunomodulatory therapies, especially if you've been able to identify immune dysfunction, you may be able to avoid steroids quite a bit. There are trials pending for use of antifibrotic therapies in children. Some of these patients will progress to lung transplant, though not most, but some, certainly with improvements in CF. The portion of kids with ILD needing lung transplant is a bigger piece. But remember to look carefully at immune dysfunction and macrophage abnormalities, because lung transplant may not be the way to go, may instead be bone marrow. So lastly, I'll just mention one of the things that with colleagues around the country, I'm grateful to have opportunity to do to try to better understand the prevalence of these diseases and advance knowledge on their features and management. And that's the US National Registry that's moved from Vanderbilt here to CHOP over the past year. We have initial 20 sites active now, and once those sites can make progress, we'll open again to additional sites to join. But this is a longitudinal observational study for children with interstitial lung disease that operates with CHOP, with IRB Reliance Agreement as the coordinating center. So when you think of interstitial lung disease, think diffuse lung disease. Remember to rule out common causes of the symptoms first, then work to make a specific diagnosis. It's been a really exciting time for me to see how much has changed in this field with many new genetic and molecular insights. A lot of our focus is still to treat comorbidities and provide supportive care, but the next phase, and what I hope you will all be a part of, is protocol-driven management and treatment trials. So until we have therapy, we need to coordinate, organize ourselves in a way that we learn together. And to do that, multi-center collaboration will be critical to accelerating progress. So this is our group here at CHOP, and I have enjoyed working with them and with colleagues around the country over the years in this field, and it's my privilege to get to share this with you today. So I'll stop and be happy to answer questions in the last minute or two if there are any.
Great talk, Lisa. Thank you so much. Fantastic. Please type your questions into the chat box or raise your hand and we'll mute your mic. Lisa, I'll kick things off. Is there any role for azithromycin or hydroxychloroquine in treating interstitial lung diseases?
Maybe. So there's a little bit of laboratory-based data for hydroxychloroquine with some of the surfactant abnormalities. It can alter lysosomal pH and may help with surfactant processing. It has a sort of role as a weak immunomodulatory agent as well. So with inflammatory disorders, that may have a role. The azithromycin data is pretty limited in ILD, but we extrapolate from other inflammatory lung diseases. So often used, limited evidence.
Great. And also want to thank you publicly for all the help you've given me over the years with some of my interstitial lung disease patients, because not a lot was known, and you when I first started seeing some of these kids, and they've been a great help. So thank you.
No, thank you. I would just say that's how we all learn, and people I showed you helped me as well, and it's really just one of the fantastic things I think about our subspecialty and how we're connected around the country. So please reach out.
Great. Any other questions? Oh, here comes one. I appreciate your input on not always needing sedation. 2-2 improvements in high-res CT. How often in your current practice do you use sedation in infants? Is the child network considering changing recommendations? As I know, as we've discussed in our group, some still cling to their prior recommendations.
Yeah, so I think we have a lot of work to do to update prior documents. From my own practice, I would say it went from almost always being sedation in infants to now being the minority. So one important thing to think about is how sure you are that a patient has ILD. If you just have respiratory symptoms and you're evaluating a child for the first time, you may need contrast. There may be other considerations in that CT approach. If you were simply doing a CT for follow-up of ILD, that might be different than a first ever CT. So these are really going to be conversations with your radiologist, and right now they're very center dependent as to the equipment that's there. But it's a big issue in the field because we did spend quite a while trying to hammer in the need for sedation and controlled ventilation.
Lisa, one of the things that with the lung biopsies is the post-operative pain management. And I know that actually the ILD group has been out front. I know and Robin is convinced her surgeons that after they do a lung biopsy, they don't need a chest tube when they do it by VATS. What are your feelings on that? Do you think that's the wave of the future?
So depending on whether they use a lasso technique or an endoloop versus a staple line, that will influence the air leak. Also depends on the clinical context and how the sick the kid is, just as with bronchoscopy and consenting, most of us will always say, and we don't know exactly what's wrong, and therefore we can't know how healthy the lung is or isn't, and the risk. There is a little bit of that, but I've had some more old school surgeons go to the endoloop and not leave a chest tube. And so it really makes a dramatic difference. And I'm hopeful that that more surgeons will start to do that for more kids.
That's great. All right, it's 5 o'clock. If you didn't get a chance to ask your question, I'm sure if you send an email to Lisa or me or Liz, we'll get the email, your questions to Lisa, and she can respond to you directly.